Let me start with a story. I'm not going to read this; it's very long. But think way back to 1825, and I found a case report in the medical literature of a case of a physician, and he wrote this himself, and he was describing something that happened to him in 1822. He wrote it up 3 years later in an English journal, and it was reprinted in what was then the predecessor of the New England Journal of Medicine. And it described a case where he was asked to do an operation on a young girl who had a rather ugly tumor on her neck. She wanted it taken off, so he agreed to do it. So, as they did in those days, they met in a hotel room, and the operation would take place with no anesthesia. There wasn't any, and she apparently was either sitting down or standing up. It's hard to tell from the case report. At any rate, it went fine. He was finishing it up, making the last few cuts to completely remove it, when he was surprised to hear a sucking sound, like air being sucked into a bottle. And the woman immediately exclaimed that she was dying, and then dropped dead. So he couldn't revive her, and the next day he did an autopsy. Back in those days, you didn't have pathologists who did autopsies, but if you were the surgeon, you did the autopsy. So the following day he did it. He found that she was completely healthy. The only thing that was wrong was that the right atrium of her heart was completely distended with air instead of blood. And the other 3 chambers of the heart had blood in them. So he surmised at that point that what had happened, for some reason, air was sucked in through a vein in the neck that he was cutting, had gone to the heart, filled up the atrium, which prevented it from pumping adequately, and her blood pressure immediately went to 0 and she died. And that appears to be the first published description of a fatal air embolism in the medical literature. Now, by now, some of you are thinking, you've probably gone to the wrong meeting. But let me tell you what the point is. The point is, what I haven't already said, is that both the operation and the autopsy were performed in front of an audience of about 400 spectators. And then later he wrote it up, and if you read this case report, it's rather short. This will be, I suppose, if you have access to the slides, it'll be on the slides. You can read it yourself. It has the name of the patient, the name of the surgeon. So it appears that at least back at the beginning of the 19th century, people didn't worry much about secrecy and hiding their mistakes. So where did we go wrong? Well, I won't go into the details here, but before roughly 1840, doctors were hardly ever sued. Medicine was a real amateur proposition. There were no standards. You took care of the patient, did the best you could. If the patient lived, that was fine. Some did give you a chicken. And if the patient died, it was an act of God, and they'd still give you a chicken. But around 1840, for a variety of reasons that are detailed in this paper, which is in JAMA in 2000, people started to hold physicians to standards. They said it's a proper way to do medicine, and physicians must act that way. Once there were standards, you could be sued for violating the standards. And once doctors started to be sued, they needed malpractice insurance. They had to get this from insurance companies. So now the insurance companies were financially at risk when a doctor had a bad outcome, and therefore the insurance company could tell the doctor exactly how to respond, if to respond, whether to talk to anybody or what to tell them. And that was over 150 years ago, and it's been going on ever since. And this is what it led to, basically. The injured patients, with their lawyers and family, are circling the protective devices, which look like wagons here, but they're actually insurance companies, defense attorneys, hospital administrators, and risk managers who are all responsible for protecting the hospital and the doctors from financial loss. That's what hospital risk management is. Has nothing to do with the good of the patient. And this is, seems to be the worst possible way of dealing with medical error that could possibly be devised, and that's what we have. So is that professional? Are we proud as doctors and other licensed practitioners to have our hospital representatives represent us this way and do this to patients on our behalf? Is it transparent? Does it support patient care and patient safety? Is it professional? Well, I would say, yeah, it's professional. There are certain professions where you sort of have to do this. If you don't, you end up sleeping with the fishes. And if this is your profession, then good luck to you. You're in the wrong meeting. But it's not our profession. So why have we continued to act the same way as mafiosos would act? Well, in medical risk management, they have done this on our behalf, and we've permitted it because it was believed, that it's been believed for decades, that if you did otherwise, if you told the truth, plaintiff's attorneys would get a hold of it, use it against you, and take you for all you were worth, put you out of business, close hospitals, etc. It would be financial disaster, and of course that would help nobody, that would also harm patients. Therefore, the consequences of that would be much worse than being open, so it justifies behaving the way I described. Well, who do we blame for this? Because obviously we do blame somebody, not ourselves. Well, we blame plaintiffs' attorneys a lot. We think that they're pretty much like pit bulls. The contingency payment system, which is the system that makes it possible for the vast majority of patients to actually sue, because the lawsuit is very expensive and hardly anybody can afford the expenses of going through the suit. So in the contingency system, the lawyer puts up the money up front, hoping to win. And of course, whenever they win, somebody's going to say the jury was irrational. But the outlook is now changing, and I'll give you some partially self-serving opinion of why I think that is. This is the paper that, the beginning of the paper that Ginny Ham and I wrote in 1999. It was published in December in the Annals of Internal Medicine. And it described our system that we had started in the late 1980s of taking care of patients, reviewing the injury review, maintaining the relationship between the hospital and the patient, and proactively offering full disclosure and compensation for injuries. Doing that 100% of the time, cheap cases, expensive cases, it didn't matter. We've been doing that at this point for about 10 years. And it also described our financial consequences. And what we found is that it was sort of moderate. It didn't really stand out compared to the payments made by other hospitals that practice deny and defend. This is the figure that went along with that paper, and the asterisk is our hospital. That's Lexington. We compared our data with 35 other similar hospitals, and by similar I mean they were tertiary hospitals, they were all affiliated with medical schools, and they all had residents that working there. And the top graph here just shows the workload of the hospitals. It shows that we were pretty much in the middle of the workload mix. We weren't lowest. The number of claims was predictably among the very highest because we were admitting everything. And the total amount of money paid out to patients over a 7-year period was under $2 million. So this attracted some attention, and probably attracted more attention than you would expect because it was published only 1 month after this was published. Well, the IOM published To Err is Human. That's the first time nationally they publicized the estimated deaths in hospitals due to medical errors. And that's where the numbers of between 44 and 98,000 deaths a year due to medical errors comes from. So this had already created a lot of interest, and while people were still interested, our paper came out and it attracted a lot of attention as well. Well, how did it start? Well, I became chief of staff there in 1986. We started the risk management committee in 1987, and our intention there was simply to put together a program where we'd be aware of what was happening in the hospital, find out if there were bad outcomes, take testimony early so that people wouldn't, leave, go someplace else before somebody filed a lawsuit, and just file all the information away in a dossier in the event that we were sued. Within a few months, basically it was damage control. We didn't think beyond that. But within a few months, we became aware of a wrongful death that was clearly caused by a medical error. There was no doubt. At that point, we sat down and decided that we just couldn't file it away. We had to tell the relatives. The relatives had no idea that this was a wrongful death. They thought it was a natural death. We decided that we were going to do the right thing and called them up and told them to come back and have a talk, that we discovered a discrepancy causing their relative's death. And they did that. We also advised them to bring a lawyer if they wanted to, because we thought that was the fair thing to do. And then after we discussed it, we had our lawyer, Ginny Ham, talk to their lawyer, and they negotiated a settlement, and within a few weeks it was done. Compare that to the usual length of time it takes to negotiate an actual lawsuit, which is in the vicinity of 4 to 5 years in the VA. Since then, that really sort of felt right. I mean, we could sleep at night. We knew that errors happened, and we thought that that was a good thing to do. So we did it the same way every time since then. And then we analyzed the financial impact and published the results, as I've already described. So what exactly did we do? We'd find out about things that happened in the hospital either through incident reports from doctors or from a quality improvement people who sent nurses around looking for things, or if a patient requested their medical records, we'd send them the medical records, but we'd look at them ourselves to make sure that it wasn't because of a bad outcome. We'd do peer reviews and ask ourselves these 3 questions. Was there a standard of care violation? Was there a medical error? And was the patient injured or worse? And the reason we did that is because these are the things that, if determined in court, would result in a judgment. A medical error without a bad outcome, without harm to the patient, is not compensable. If you give somebody a Tylenol instead of an aspirin, you can't be successfully sued for that. But so those are the things we looked at. They had to be significant errors. We always involved the practitioners. We told them what we were doing, and they asked them for their opinion, and we came to a consensus decision. We got peer reviews as well, and then we would disclose. And also discuss settlement options, because disclosing without trying to make the patient whole seemed ridiculous, to tell you the truth. So what did we tell them? Well, I did most of the disclosures myself, and it was just a discussion between myself and whoever was in the family. Sometimes it was a whole group, including sometimes other outside relatives, the minister and other people, and I'd tell them the entire truth sympathetically and completely, accept the responsibility, and describe what had been done to prevent further similar incidents. We also advised them to retain an attorney experienced in malpractice litigation to represent them. And why did we do this? There are several reasons. It reassures the patient of fair treatment, so that they don't come back 2 years later because some nosy uncle told them they didn't get as much money as they should have. And if they felt that way, they should go to their attorney rather than to us. It reassured us that we could negotiate with someone who understood damages. Normally patients don't. Oops. Regardless of our good intentions, our primary responsibility was for our employer, which was the VA. So the patient needed his own advocate. Sometimes they didn't want a lawyer because they didn't want to have to pay the lawyer part of the compensation package. And in that case, we would negotiate directly with the patient. The year and a half later, this paper was published, Crossing the Quality Chasm, which presented solutions to the medical error problem. And transparency, I did a search on the whole book looking for transparency. It showed up on many pages. And after that, transparency became a buzzword. Everybody was talking about it. The Joint Commission started to require hospitals to disclose unanticipated outcomes, however you want to define this. Press and commentators began to focus on the apology. A lot of people thought this was just a ruse to, once you apologize to the patient, that was enough, you didn't have to do anything else. For us, it was never about apology. It was about disclosing information and compensation. But sorry became a buzzword anyway. And then apology exclusion laws were passed, and it's now 37 states, protecting doctors from having an apology used against them in court, which is a little disingenuous, I think. Sort of forces you to lie in court. Then several hospitals and healthcare systems announced adoption of disclosure practices, often associated with public disclosure. This is a short list of these hospitals on the left and hospital systems on the right that have stated that they are using this or similar programs. I'll say something about the two in red, which is hard to read, University of Michigan and the University of Illinois. The University of Michigan started their program, which was styled after ours in 2003. It is not a government hospital. It's a nonprofit hospital affiliated with the University of Michigan. Its claims, they reported after a few years that all of their expenses and the time to settlement decreased drastically. They published their results in 2010. They're still doing it, and the same person who started is doing it, and they reported with numbers remarkable decreases in lawsuits, costs, trials, and time to resolution. Also, as we had 11 years before, they linked the openness to patient safety benefits, because once you settled everything with the patient, you could deal with the systems problems in the open without being afraid you're going to get sued. These are the number of how incident reports increased in Michigan over that period of time, because it was encouraged and because people felt that they were being dealt with properly, not against the doctors and nurses, etc. In 2011, the University of Illinois published details of their risk management and safety program. It used similar concepts. Their program was only 2 years old when it was published, and they did not report the amounts, but they have claimed that there's been no increase in either the number of suits or the payouts, and the reference is there as well. Other countries have gotten on the bandwagon. Canada has a national system. The United Kingdom started one in 2006. It just lied there. Nobody paid any attention to it. They relaunched it in 2009, and as far as I know, not much has happened there. Wales have developed their own system in 2008. Australia is piloting different models in their different states. And New Zealand, which is sometimes quoted as being involved in this, has a no-fault system since 1970. Copic is an insurance company that started some program like this. I'm going to jump over this because just for time, but this, you can look this up on the internet. They have a pretty nice program, but it's really very limited. Massachusetts Alliance for Communication and Resolution, following medical injury, started in 2012, and they are trying to get the entire medical hospital industry in Massachusetts on this, including the insurers, and their commitment is to transparent communications, sincere apologies, and fair compensation in cases of medical harm. They're just getting started, but they're really pushing hard on this. They're also committed to implementation of communication, apology, and resolution. They have lots of acronyms here, and you can look that up. Also, the link is at the bottom. There's a whole bunch of advocacy groups. Some are here. There's the Medically Induced Trauma Support Services, or MITS, Mothers Against Medical Errors, Pulse, etc. And there are more jumping up every day, generally driven by people who have had impressively bad results with medical errors, either themselves or a family member. In academics, there have been more than 400 peer-reviewed studies published on this since 1999. All of them are supportive, but many claim, with very little data, that money is saved. Others argue, with no data whatsoever, that costs could increase. So do we need more research? There are clearly too few data points. The only hospitals that have published their program in detail are the ones I told you about: Lexington, Michigan, and Illinois. And only Lexington and Michigan published their financial consequences. So that's not enough. That's not statistically significant. So do we need more data? You could also ask, do we need more data to determine whether working for a living is more or less beneficial or lucrative than stealing from liquor stores for a living? Nobody's ever done that study, and they're not going to, because it has nothing to do with how much money it costs. It is not a science question at all. It's a decision on how we behave in society. And that, I think, is the crux of the matter. And so long as it's affordable, as it doesn't drive us out of business, we should be behaving in a stand-up manner. It also involves administrative competence, because if you're an administrator in a hospital and you don't have a good handle on what's going on there, you don't know whether, what's going to jump up out of the woodwork and bite you, and you might be tempted, just for your own peace of mind, to let the risk management system handle it and let the courts handle it. I'll jump over this. Are there obstacles? Oh yeah. There's still a lot of people who don't really believe it. They think this is just some starry-eyed liberal thing, or it may only work in certain hands. This came out as soon as we published. We saw lots of people saying it could only be done in the VA, it couldn't be done in the private sector. And then Michigan published, and they said, well, it may be done in certain hands, but not generally. People looking for all sorts of excuses. There is some published research that suggests that disclosure practices would cost more by inviting more claims. That's totally theoretical, and it has not been borne out in actual practice so far. Defense attorneys, they're trained to defend, not to coddle people. They're hired to defend the hospital against financial loss. They're hired guns, and a lot of them just can't make the 180-degree turn to deal with this, and probably have to be replaced with people who can. There's also a lot of money at stakes. If you're a risk manager and you're trying to do this and you're not certain that your boss is on board, what happens if you make a payout that your boss thinks could have been avoided if you'd simply kept your mouth shut? Will you lose your job? That's a very powerful incentive to not go along. And then a lot of folks don't think much of people who sue and their lawyers. But what is this not? I want to make this clear. This only comes into play when there's been an actual error, a standard of care violation, and damage is done. This is not a payout for any bad outcome. If the legal standard, in other words, we'll only pay out if the legal standard is violated. If not, still transparent, Try to maintain a professional relationship with the patient and the patient's lawyer. Cooperate with the lawyer, send records, don't dig your heels in, don't slam the door, but decline any settlement. After all, if you're right that there's been no violation of standard of care, examination of the records are only going to support you.